Good afternoon, everybody. How's everybody doing? Is the energy still here, or are we all just looking at it? Good. All right. Sounds good. Well, we're going to have a little bit of fun today talking about DPC and the health insurance system. You know, it's an interesting topic to moderate and to talk about because so many of us are here in this room and in this industry because we were deeply disappointed by health insurance. We were frustrated by health insurance. And honestly, if we didn't have to deal with health insurance for the rest of our careers, that might be soon enough. And yet, there's a conflict because the vast majority of medical services, healthcare services, and pharmaceuticals in the United States are actually financed and paid for by the healthcare system, by health insurance. And so, when we think about the trajectory of direct primary care, and we think about the way it's growing right now and how exciting that is, and then we think about, well, what's possible if we harness what's great about health insurance and harness the power of health insurance to really supercharge the growth of direct primary care. There's some exciting possibilities. And though we are in Denver, this is not necessarily a pipe dream. We are fortunate that there are a number of very innovative, thoughtful health insurers out there that are trying to figure out the same problems we're trying to solve. That is, how do we create great access at a fair price for primary care and other services in a way that doesn't drive doctors crazy and create burnout. We're super fortunate to have Frank Wu here with us today. He is the CEO and co-founder of Taro Health. We have Kyle Rickner here from Primary Health Partners, co-founder of that direct primary care group. And our agenda for the next several minutes is I'm going to give both guys a chance to talk about themselves and their organizations. I'm going to tee up a few questions to try to get a little bit deeper into how they are putting these two disparate things together, making it work. What are some of the things we've tried that have worked and tried that haven't worked? And then if I do my job correctly as a facilitator, we're going to have at least 5 minutes left for questions and answers with the group, and we'll get you out of here on time. Does that sound good? Let's go. Frank, you first.
I didn't realize we could curse on stage and say insurance.
Thanks so much for having me. You did it again.
Sorry. Yeah. I'm gonna keep it clean for the rest of the time.
Yeah.
So great to see everyone. A lot of friendly faces in the audience. Excited to tell everyone a little bit more about Taro Health and the work that we've been doing with other innovative DPC practices like Primary Health Partners. Taro Health is a health insurance company that has been built from the ground up alongside direct primary care. I know there's irony in that, and so I'm excited to kind of unpack and walk through what it means to actually build a health insurance company together, hand in hand, and rebuild the system from the ground up. Taro Health is the first and the only health insurance company in the country that offers a direct primary care membership for free on the healthcare.gov marketplaces. So patients can go to healthcare.gov when they sign up for health insurance every year, and they can select a plan through us that allows them to get the direct primary care experience, the entire membership, completely at no cost, which leads to everything that everyone's been talking about over the last couple days, the amazing experience, the great care, the access to the doctor that people are looking for. And we've been doing a lot of work, to make that happen, and especially in a way that ultimately supports the direct primary care movement and doesn't get in the way traditional insurance companies have done. We also, maybe more importantly, we are proud to be part of the supporting cast as part of the Princeton offense that Dr. Rickner and Dr. Lockwood and the Primary Health Partners team has been building out in Oklahoma.
Yeah, I was absolutely amazed when I talked with Frank Wu and his partner Jeff Wan that these guys wanted to start an insurance company, build it from the ground up, and they wanted to come to Oklahoma. And I don't think hardly anybody in this room understands what is involved with what I just said. They had to have so many meetings with the insurance commissioner, and they were trying to jump through all the regulations. And then on top of that, if you're going to start an insurance company and provide a product, the hardest way to do it is to put it on healthcare.gov. There's a further layer of regulations around that. So I've enjoyed working with these guys. The way that I view this is that we in DPC need to have a widening and a broad network of customer acquisition sources. And I want them to, in the future, be as many passive customer acquisition sources as possible that doesn't require any of us to spend big money on marketing or do efforts or anything, but there are actually vehicles that deliver the DPC product to customers directly that then bring them to us. And so that's exactly what we've been experiencing with Taro Health. With anything that's new, there's always road bumps along the way, but we're big fans of this. We think this has incredible potential, and I'll love for you guys to hear what Frank's vision is for that potential for the future.
Yeah, so maybe we can get into a little bit more detail about what you guys are doing, how the benefit design works, how you're pricing it, how you're splitting up the money. How are some of the mechanics working right now?
Yeah, I'll start with that. So the Taro Health product is a full major medical health insurance plan. So there's been a lot of talk, the last couple of days about bringing DPC into insurance. How do you capture the full value of it? We're lucky to work with amazing people like Fritz with Milliman, who've helped us really design the product from the ground up, such that we can capture, the full value of direct primary care and continue to offer it to more audiences. So yeah, the core of the Taro Health product is it's a full major medical insurance. That means that it covers everything from the preventative care that you might get every year, all the way up to cancer and hospital visits and things like that. When people buy our product, they're buying it instead of buying Blue Cross of Oklahoma, they're buying it instead of Aetna or Cigna. They're trusting us to be their health insurance to cover everything that might happen for that year. That product, our product is free direct primary care membership. We work closely with the direct primary care partners to really understand who are the other specialists, the other hospitals in the area, the lab providers, the x-ray providers, everyone else that a patient might need over the course of the year that the DPC might refer to, and we build the rest of the plan around that directly as well. So not only do you get the amazing direct primary care experience for free, but if you need to go to a specialist, you'll know exactly how much that's going to cost. You'll have a great partner because it came from a referral from our DPCs. And ultimately, if you do unfortunately have to end up in the emergency room, you'll still have the full comfort of knowing it is a regulated health insurance company that follows all the rules and restrictions of the Affordable Care Act, making sure that you are covered in any situation that you might run into. So.
I think one of the exciting things is the population that goes on to healthcare.gov and gets their insurance there largely was a population that we didn't have much access to. So now all of a sudden, these people that would not have been patients in DPC practices can now come to a DPC practice. As far as how it works, we had great conversations with Taro, and they wanted to understand what do we need our fee to be and how do they work that. And it's worked into the premium. And so when a member chooses Taro Health and they pick their DPC, those payments just happen automatically on the backside, just like we want them to. I think it's really important. I want all of you docs in the room to hear, we do not submit any claims to Taro Health. Yeah. These genius guys figured out the backside tech about how to make that process happen so that they meet those regulatory requirements. But not a single one of our doctors has to do an extra click because these patients are from Taro Health, and I thought that was an absolutely brilliant thing. The other thing about it that was really exciting for me is that, as you might know, many of the patients on healthcare.gov receive government subsidization for their plan. So many of them, we had patients actually that were paying us. We informed them about the product. They went, grabbed the product, their subsidy was enough. They were paying less for the full insurance product, which gave them the membership than they were paying for us. And so it was really exciting, and there are actually a few people that it ends up being essentially free to.
Yeah, that's a great point and a great setup for me in a couple of ways. Kyle, for the new members that are coming in, that are getting insurance on the exchange and coming to you guys for care, how the demographics different, how the healthcare needs different, and has it changed your practice at all?
So the answer is it's not different. They're the same sort of demographic that we're used to seeing, and we didn't have to alter our processes, which was very important for us. And Frank and Jeff were very intentional about the design, about how this would go. So once they join, we get that membership information. We reach out to them like we do any other member. We bring them in for a visit, initiate that care, and the rest of the process and everything is just the same. So it wasn't a different demographic, but it was people that all of a sudden could not believe that they went on healthcare.gov, did a few clicks, filled out some stuff, and they got us.
Yeah.
This was not what they were expecting. So there were some really surprised patients in a good way.
And I want to acknowledge a comment that you made about you haven't had to change your workflow, you're not submitting claims, you're not submitting anything else. Frank, talk about how you're doing that, because I'm close enough to this to know that's much more difficult to do than what you just described.
Yeah, no, I'm a technologist by background. I'm not a health insurance person, in my career. I run a health insurance company now, but it's new to me. And I think when we discovered the direct primary care model, we realized how special it was because it was such a breath of fresh air compared to how traditional healthcare is.
Yeah.
And anything that we were to do that would change the magic of direct primary care would ruin it. And we recognize that, all of you in this room that are DPCs have taken the initiative in your past to leave a broken system and say, hey, I'm going to vote with my feet and say, I don't want to work in a system that forces me to do things that I don't want to do. And I think that's true today. If we do something that forces primary health partners to go back to the way things used to be, they will leave. And we won't be able to work together. And I think that's a really, really important social contract that underlies everything, is that we understand where you come from. We understand that there's an opportunity to do something differently. We use modern technology, and we have amazing partners, electronic health record systems like Elation and Acute. We get to work with amazing people like Hint to go build these systems. And when you stitch it all together and you realize that you can take modern technology and data and AI and all these things and go create a new system, and you can do it together hand in hand from the ground up. You're not chained to the existing system. You're not trying to bring it back to an old insurance company that doesn't understand what you do. You have the opportunity to do anything you want, right? We chose to be an insurance company because it gave us essentially the full ability to go build a system from the ground up. We recognize the role that insurance does play for people. We don't want to be the traditional insurance company, and that's true for DPCs, but it's also true for hospitals. It's true for the patients that we serve. We recognize that they can walk and they can leave, and I think that's a huge part of being an upstart and doing something differently. Is you have that responsibility to do something better as opposed to what people have done in the past.
So let's go a little bit deeper into that. I know you guys have confronted a lot of technology and integration challenges as you put these two things together. Tell me more about some of those challenges and obstacles and how you've overcome them.
How often do you think about the end of the Roman Empire?
Every once in a while.
Okay.
Yeah.
I think about it a lot. And so I think that there's a small academic field talking about the collapse of social systems and complex systems. It's called collapsology, if you're interested. And there's a book that I was skimming called The Collapse of Complex Societies. And in it, the general thesis is that systems basically scale to the point where the complexity no longer can be supported by the infrastructure that exists. And I think that's very true for direct primary care. The healthcare system that has emerged over the last couple of years has created so much complexity that ultimately we've reverted back to simplicity. But the reality is when complex systems fall, like the Roman Empire, usually the system that comes out on the other end is better than the one before. But if you're reverting back to simpler systems, how is that possible, right? And I think the answer is actually technology. There's actually, I think, two flavors of technology here. The first is actually this idea of cultural technology, which is what this room is today and what this conference is able to provide, which is this idea that every one of you carries in you, the historic precedent of what has not worked. And also you have all the hopes of what could happen with a new system. And that is technology that I think is not the same as when we traditionally talk about technology in the sense of data and science and tech, or the light bulb even. But I think the fallout of the Roman Empire. Sorry, I'm gonna stop. I'm not a meme. I'm gonna keep going. I think the social technology is part of that contract to go build something differently. And then the second technology, I think, is what you were actually asking me about, and I apologize for detouring a little bit here. The second technology, I think, is about actually, using that cultural technology and applying it in new ways with modern tech in the traditional sense of data and automation, and now in the age of AI, harnessing that technology and directing it towards new and novel approaches. So, for us, that means things like integrating with the government, collecting the really, really messy 834, 837 files, EDI files, integrating that with electronic health records, integrating that with Hint payment records, and then ultimately, deploying a product to the end user that actually doesn't care at all about what an 834 is or an 837 is. So, yeah. Hopefully that answered your question.
That was awesome. And Kyle, you were about to make a comment, I cut you off. What were you about to say there?
I was just wondering if you knew about the fall of the Greeks. I just wanted to point out that all that cool stuff means the dumb doctors don't have to do anything different. We just do exactly what we did. That's why I appreciate these guys. I did want the room to know, the big picture here for me is we have just a little over 300,000 people in Oklahoma every year that go on healthcare.gov and find their coverage there. They don't often find care there, but they find coverage. And now we're expanding into 27 of our counties, is that right? 27 counties. And so this product will be available to more than a third of those people, or actually it's a little more than that, isn't it? And so this is a passive customer acquisition channel that we're going to be able to leverage and bring lives into DPC. Here's the exciting part. There's a healthcare.gov for every state. And we're going to do it really well. It's going to work really well. It's going to grow in Oklahoma. It's going to grow in Maine. And then it can come to other parts of the US. And so I'm so excited that DPC is growing as a group because they work really hard to work with DPCs in your state. And this brings a service to people in your state that normally they might not be able to touch it.
Yeah. Boop. So 2 more questions, if I can. So on this journey, what has surprised you guys? What's happened in a way that you couldn't have foreseen?
I think you would appreciate this. You've been in my seat before running a health insurance company. It's really hard. And I think if we had known all the different challenges going in, I don't know if we would have gone down the same path.
Yeah.
No, I think the really cool thing has been that, our thesis all along was that the opportunity to go change things was to be at the top of the strategy and operations. But in this space, it means being the health insurance company and actually rewriting the rules. Yeah. And I think that's been a really, really awesome opportunity to start from scratch and say, okay, well, a lot of really, really smart people built the BUCAs. They created the systems that we're currently in, but what did they get wrong, right? And actually go through that from first principles and look at the actual regulations, look at the actual data contracts, understand exactly why things are happening the way that they are, understand which things should continue to be done the way things have been done in the past, but then actually more importantly, identify the ones that you can change. And when you're in the driver's seat and you have amazing partners who can help you brainstorm and problem solve the solutions, I think that's a really, really cool ingredient. And I think we've been surprised by just how much collaborative nature we've had with folks who, before us said, hey, insurance is not anything I want to ever touch. And I think that's been really, really special, is having amazing partners along the way to go build something new and something special.
I think 2 things. The first is any time that you do something new, there's going to be some points of friction, right? So I think the first point of friction that we discovered together is that people get on and they believe they're signing up for insurance. They click and it's a very passive thing and they think they're done. And so we learned that, them having to actually go on after that and select a direct primary care doctor, the educational piece and getting that to the endpoint customer was a challenge. So some of them that chose Taro Health, they literally didn't know what they were getting. So that's being improved upon. And then the second thing is, it's a brand new insurance company. And in Oklahoma, Blue Cross Blue Shield dominates the landscape. If you show up at the urologist office with your Blue Cross Blue Shield card, there's no questions, they know. But when you show up with your Taro card, they would think you want to look into the future or something. And so I think we had some endpoint point of care services that were fully contracted appropriately, and there was some friction there. So these are things to be expected, but they're operational challenges. Nothing's going to be smooth. And We're really looking forward to year 2 because I think we've gotten through some of those. We've recognized the challenges, and Frank and his team has solved for a lot of them.
That is a big one. I'll just touch on that too. When you are new, I think this is true for any company, including those of you who are starting your DPCs. I think the first long sprint really is pushing a boulder uphill. And I think Dr. Rickner was really alluding to this is when you're a brand new insurance company and everyone is familiar with the blue locally, when people see your logo for the first time, they say, oh, this is interesting, but it's not Blue Cross, right? And they say, oh, well, should I trust this new company? Should I, and health insurance is a big responsibility, right? We can cover, if you have a bad year, and hopefully you don't, we could be covering tens of thousands or hundreds of thousands of dollars or more, for your care. And so I think that pushing that boulder uphill is something that we have to do every day. It's something that you have to do as you start your business, and I think that's true for any business. But hopefully you get to the point where you keep pushing, you get better and better step by step. More people will see you and recognize you, and that word of mouth spreads, which is how DPC has grown so quickly into what it has become now. And eventually, at some point, that boulder hits that tipping point, and you suddenly just go downhill, and everyone says, "Wow, I had no idea where this came from." And I think that's what we're really building towards. Is someday people will be saying, "Hey, I got my Taro plan, and I'm super excited about getting DPC," and they know everything about how this movement got started and all the work that all the DPC physicians and folks on our team have been doing to go build a new system from the ground up. So.
Yeah.
I will say the insurance companies, they don't always listen to us. I suggested renaming it to Purple Cross and Shield, and it would have been more relatable, but...
We might have done it if you covered the legal fees.
Well, look, we'll get you out of here on this. You mentioned you are expanding into some additional service area in Oklahoma. That sounds exciting, and I know what that entails too. What else is on the roadmap for you guys? What should we expect to see from you all working together over the next couple of years?
Yeah, I mean, a big part is we want to continue being better for our DPC partners. We thrive on feedback. That's the only way we can get better, and so. Yeah, we're trying to build better networks. We're trying to build better technology. We're trying to build better integrations into the existing workflows that they have. I think we're also really excited about innovation in this space. Direct specialty care is something that's taking off. We'd love to work with more of those practices. We'd love to build more of the back office, such that anyone can work with us and work in the way that they want to, and it's not only
direct
primary care doctors. So,
I think one of the lessons that were learned from year 1 is that we went to market with a very narrow market. So it's really broadened this year. You've added multiple health systems, but we've worked together around that idea. And what I see is once the value proposition proves itself out, so that everything that Fritz said comes true in this arena, there's actually the ability to lower the cost, which widens the market penetration. And so the number of people that adopt it go up every year. And so what we're expecting over the next few years is an incredible stepwise adoption. And if that happens in Maine and Oklahoma, like I think it will, then it gets to come to other states more readily.
Yeah, that's great. We've got just a few minutes left, so I would like to open it up to audience questions. I see a hand here. I see a hand back there. If someone could assist us with the microphones.
Hi. So I live in New Mexico, which has the closest demographic to Oklahoma comparative to any other state in the U.S. We also have a much wider income span, similar to Oklahoma, but significantly less resources. So I'm just curious, Maine and Oklahoma are not similar demographic or geographically. So was that decision just because that's where the DPC stuff was already established? And if so, but also, is there room for you guys to expand out into other states, New Mexico specifically? Just because I think that would be a huge benefit for community, but also for other practices in the DPC or hybrid model.
Short answer is we'd love to come to New Mexico. We want to get this right, and so we're taking it kind of one step at a time, and we'd love to be in all 50 states. I think the problem that we're solving is not one that's limited to any specific state, county, demographic. We think it's a larger problem than that. So yeah, we'd love to get there one step at a time. Maybe just on the question of why Maine and Oklahoma, and you kind of alluded to this, they're actually different. And that's by design. I think as we're in this early stage, as we continue to learn, it's important for us to understand how this will apply to different demographics. Within Maine and Oklahoma, you have very rural audiences, you have very urban areas as well. It's actually really important for us to be able to understand where the model works best, how to adapt it, into more rural areas. A lot of Oklahoma is actually very rural, and DPC, and by extension us, looks very different in that area as opposed to Oklahoma City downtown. So it's actually good for us to be able to experience different markets. This is kind of nuanced too, but Maine is a market that actually operates their own independent state-based marketplace called coverme.gov, and so Oklahoma, like many other states, operates directly on healthcare.gov. So there's also operational and data and tech integration challenges for us as we kind of learn how to navigate those different things. But for us, it's actually exciting that we get to see different audiences and learn from the different diversity there.
Come on over here.
Where do you think that we could get help from a state-specific, so we're in Arizona, so would we be talking to our state senators to discuss this as definitely a plan that we'd want to have added to the ACA underneath healthcare.gov in our state? Would that be additional helpful resources for you?
Yeah, I think that's, so the question, if the microphone didn't pick it up at first, was about, there's a lot of politics and regulatory as, underlying the product that we're building, and how do we actually help bring that to more states? So, I think the suggestion was getting involved in meeting with senators and policymakers in your state, and I think that'd be great. We want states to want us. I think it's always exciting when, they're excited about what we're doing. The reality of how our product works is we work really closely with the individual state bureaus of insurance in every different market. So that's kind of the core, thing for us, is being able to meet those folks, continue to build out our product, demonstrate, our track record, and then continue to move into the new markets.
And I think the penetration of DPC in the market and the cooperation of the DPCs in the market is a massive thing. And I don't want you to think that this is a Primary Health Partners product in Oklahoma. We're using a lot of different DPCs, which I'm excited about. There's a couple of them in the room from Oklahoma, I believe. And so this is a way where we can collaborate, work together, and realize this can be a really good thing for all of us.
And the way this often works with a new insurer coming into a market is the state insurance commissioner in that state is highly empowered to determine if you get a license and a C of A or not. And so often support from a local provider community can be really helpful. So, if and when Frank and his partners are ready to come into your state, be ready to stand up there with them in front of that insurance commissioner and say, we know these guys, we like these guys, we'd like to see this alternative in our state, and we're supportive.
All right, thank you all so much. Oh, there's one more question.
One more, we've got one more.
Yeah. The question was, why am I doing this?
Is this a mental health provider?
Yeah. I might need to do the mental health check that Bruin Health was offering earlier. No, I mean, there's a few things here. One is more personal. A few years ago, way before any of this, my parents ended up leaving the employer-based health insurance system, and they ended up in the healthcare.gov marketplaces. And they were paying thousands of dollars and hadn't gone to the doctor for a couple of years. Unfortunately, that's really common, across the country. And they came to me and said, "Hey, you are smartish. You are, hardworking-ish.
It's really smart.
You are sort of in healthcare." And they said, "Can you help me make sense of this?" And I looked at the insurance paperwork, and I looked at their plans, and I had no idea what I was looking at. It made no sense to me, and I think that's what the majority of people when they look at their health insurance experience. And so, I actually ended up getting licensed as a health insurance broker, not because I had any intention of selling health insurance, but because I wanted to understand how the system worked from the other side. And then I went back and looked at the plan documents, and it turns out it wasn't that I didn't understand, it was just really bad, to begin with. And so, that I think became a driver. I wanted to create something my parents would use. I'm on the individual market actually myself, so I want to create something that I'll use. So I think that's part of it. I think the other side is when I've discovered DPC, and actually, Hint was a big part of that as well. The conferences and the recordings online. I just realized how amazing this movement was, and really wanted to support. Our first product was not a health insurance company. We actually, my co-founder and I, Jeff and I basically became kind of the pseudo office manager for about 40 different DPCs across the country, where every first call hit our cell phones. And we were trying to help with marketing, we were trying to help with acquisition. And what we kept hearing from the patients that called, the first thing would be, hey, do you accept Blue Cross? And we'd say, no, it's actually not, it's not an insurance-based practice, it's a direct primary care practice. Have you ever heard? And they'd hang up in the middle of the call. I'm sure all of you have experienced that. So I think during that experience, and then combined with talking to the DPCs, this idea was actually not ours. It came from the community. It came from many of the doctors in Maine. Dr. Lisa Lucas is here, who's our DPC medical director, and has been core to building this out as well. A lot of other independents that Dr. Rickner mentioned as well. And what we heard from them is, on the doctor side, you don't want to accept insurance because of what it has become and all the complexities, but you also recognize the role of insurance and how it plays into how people get healthcare. I think that's both patients and how they pay for healthcare, but it's also physicians and medical school students and residents, right? When they think about practicing medicine, they also think about the insurance system. And so, yeah, I think a combination of hearing it from the patients directly and saying, if only this could be part of my insurance, I would totally do the direct primary care thing. Combined with physicians saying, hey, I wish the ultimate vision here is if we could build a new system and we could create a new insurance company from the ground up that supported direct primary care in a truly native way. And so all that together kind of became who we are and why we're here and why we're committed to being here for forever. So yeah, thanks for the question.
Hey, thank you everybody so much. Thank you to our panelists. Really appreciate your participation.
Thank you so much.